Hello, my name's Carri Brown, and this is my capstone presentation. Section 1 is the case conceptualization, and Section 2 entails 3 different types of reflections. My field placement was at the Health and Hope Clinic, which is a non-profit organization that provides free medical and mental health services for uninsured and low-income clients. The client that I chose was a 53-year-old woman presenting with anxiety, trauma-related symptoms, grief, and stressors connected to family and finances. Now, the methods that I chose for engagement were building rapport based on Health and Hope Clinic agency policy, understanding practice context, as well as cultural and faith responsiveness. Engagement began with warm, trauma-informed communication, as well as matching the client's needs to serve uninsured low-income population. I used active listening, validation, and a supportive tone at every chance that I could. I incorporated the clinic's mission of accessible holistic care by adjusting the pace of sessions to align with the client's chronic stress, transportation limits, and socioeconomic barriers. And therapy was framed through a strengths-based and person-environment lens, as well as the client's treatment plan was integrated with her own identity as a Christian, being respectful during the rapport building, as well as using shared spiritual language when appropriate to enhance trust and safety, as well as humor. I definitely use a lot of humor with all of my clients. Now, the human and behavior frameworks used was, just recognizing the effects of her childhood trauma, chronic stress, caregiving strain, and the grief on her present functioning. Applied trauma-informed principles to reduce overwhelm and support emotional safety. The engagement across different systems, like the individual system, validating her emotions, normalizing anxiety responses, and providing lots of psychoeducation. On the family level, exploring her marital communication cycles and family role expectations. On the community level, connecting her to a women's support group and a art therapy group to expand social supports. On the organizational level, collaborating with supervisors and integrating agency procedures and ethics. And then on the spiritual level, just ensuring that I supported the client's use of faith as a coping mechanism and source of resilience. As well as maintaining boundaries and confidentiality. Definitely helped foster trust. Now, for her assessment overview, the biological factors were chronic pain and multiple medical conditions. At intake, she brought a very large bag that had 20 plus prescribed medications for all of her medical conditions, and she reported that she was seeking to reduce her medication. She didn't want to have to take so much medication for every little thing. Psychological factors, she certainly had symptoms consistent with PTSD, major depressive disorder, and generalized anxiety disorder. She also had persistent grief, trauma history, and emotional dysregulation. She did also report a previous suicide attempt that was roughly 4 years ago, and she said that her grandson was her current reason for living, as well as her spiritual beliefs. The social and environmental factors, obviously low income and uninsured. She's the sole caregiver for her grandson. So her son is actually incarcerated for selling and using drugs, and that's why she's the sole caregiver. Faith community was one of her primary support systems, and her marital stressors increased her symptom severity. Now, my client is self-referred, so she reached out all on her own for help in all of these areas. Now, the presenting concern that my client showed, she described having, again, persistent anxiety, intrusive memories, emotional exhaustion, chronic pain, grief following multiple losses, and again, marital communication issues. Her symptoms, she said, interfered with her daily functioning, motivation, sleep, and concentration. Now, at intake, we did 4 different standardized assessments: the PHQ-9, the GAD-7, PCL-5, and the ACEs. And her scores definitely appeared to be consistent with MTD, GAD, and post-traumatic stress disorder. Now, her mental status exam, the way that all mental status exams are done at the agency are basically filling out blanks of the one that's within the agency portal, so I'm just going to be reading off those categories now. Her appearance, she was well-groomed, appropriately dressed, no psychomotor agitation or retardation. She was fully oriented to person, place, time, and situation. Her behavior was cooperative. She was very engaged. She maintained appropriate eye contact, though she did get tearful during certain topics that we discussed. Her speech was at a normal rate and volume, though slightly rapid when she would describe certain distressing events from her past or her grief. Her thought process was linear, coherent, and goal-directed. She had no clear evidence of a thought disorder. She's had no delusions, hallucinations, or perceptual disturbances. She did express sadness, fear, and lots of worry related to trauma and current life stressors. Her mood and affect was very anxious, sad, tearful, but congruent and somewhat controlled despite some of the dysregulation that was happening. Her insight and judgment demonstrated awareness of emotional patterns and was intact. And she doesn't have any current suicide ideation past her prior attempt. And her concentration was mildly impaired by her anxiety, but certainly functional, and her memory intact. The treatment plan was focused on processing unresolved grief related to the loss, specifically of her mother, reducing anxiety and depressive symptoms, improving communication in her marriage, and strengthening self-care routines, daily self-care routines. The interventions were chosen using constructivist theory, systems theory, and CBT to support emotional regulation, meaning-making, and behavioral change, as well as narrative therapy, mindfulness practices, journaling, structured communication skill building, and self-care activities were integrated to promote holistic healing consistent with NASW ethics and values. CBT worksheets were used to identify cognitive distortions, challenge negative thoughts, and link thoughts, feelings, and behaviors through the cognitive triangle. A lot of the worksheets that I gave to her either came from the website Therapist Aid or from just a giant binder that the agency had that you could pull from. Mindfulness and breathing techniques were practiced in session and strongly encouraged outside of session to help reduce anxiety, increase present moment awareness, and support her emotional regulation. My client completed journaling exercises to track her triggers, automatic thoughts, and emotional response, which strengthened insight and also supported trauma-related interventions. Now, narrative letters were given as a homework assignment, I think at session 3, to her mother and her younger self, both to support grief processing and meaning making, helping her to rewrite the story from guilt towards acceptance. Now, initially, she did not complete those for roughly 4 to 5 weeks, though in that time she did do her exposure-based steps, like opening the blinds that showed her mother's home, visiting her grave, and cleaning the grave as well, keeping it clean. Those definitely helped reduce her avoidance and encouraged emotional tolerance, which then supported her being able to complete those letters later on. Systems theory helped with the exploration of her marital communication patterns. Role-play exercises were used in session to practice assertiveness, reduce over-communication, and strengthen boundaries. She expressed in intake that her husband communicated like not at all, basically. That she was often talking 95% of the time and he was not talking at all. A self-care bingo plan was used to promote behavioral activation and daily structure, as well as gradual re-engagement in meaningful activities like arts and crafts, outdoor time, and spiritual practices. I got a blank bingo card that we filled out together with all of the things that she would be comfortable doing. The client was also referred to a women's empowerment group and an art therapy group to better enhance her support networks, as well as creative coping methods. Now, she did not attend the women's empowerment, but she did attend the art group, and she reported that she really enjoyed the group. She enjoyed being able to socialize with other people in the group and just painting. She expressed feeling more relaxed, for sure, after a few sessions that she attended. Consultation was certainly used with supervisors and other interns at the agency just to ensure ethical and culturally responsive intervention planning that better aligned with best practice standards at the agency and NASW values. Her symptom measures over time, so like the measure scores that were taken at intake, the PHQ, the GAD, the PCL5, those were all taken again later on in treatment. So at intake, her GAD-7 was 18. After 2 months, it was 14, and at 6 months, it was 9. Her PHQ-9 was 19 at intake, 15 at 2 months, and 10 at 6 months. Her PCL5 was 49 at intake, 42 at 2 months, and 6 months she was 31. Her scores, I think, showed steady reduction in her anxiety, depression, and PTSD symptoms. Weekly mood ratings were also taken at the beginning of each section on a scale of 1 to 10, and those ratings also showed upward progress. I think initially she had a 4, and her last score, I believe, was an 8 or 9. Journaling and self-reporting was also used to monitor her triggers and cognitive patterns over treatment, finding any and all ways to improve upon all of the things that she was doing. Time series tracking was also used to manage, like, adjusting the support that she needed. Like, the bingo sheet was given with a 2-week timestamp of, completed after 2 weeks, and it was extended to 4 weeks. And then the narrative letters I had initially given her, she didn't complete those until 5 weeks later. My client's strengths would certainly be her resilience, her motivation. She had very consistent attendance and high engagement. She was very open and willing to try all of the CBT tools, mindfulness techniques, and art-based hacks. She had a lot of increased insight, I think, throughout therapy. Self-awareness. She was very self-aware, even in the beginning. Her barriers that she faced would definitely have been her chronic anxiety and the intense grief of her mother and the guilt that came along with it. I think it slowed a lot of the progress because, sort of in the middle of the progress, she would often bring it up again during session and become tearful, as well as the occasional difficulty with completing the homework, which that sort of just was because of probably the amount at which that I gave her homework, so that was probably also a barrier that I was creating, which is why I used the time series adjustments to make up for that fact. As well as another, I think, strong barrier would be her physical pain and the limited resources that impacted her functioning. All supported by her high ACE score. The adverse child care experience score, she was a 10 out of 10. Which was definitely linked to, her long-term health and emotional impacts. The outcomes of the interventions, I think, were pretty good. When it came to the CBT, she showed a lot of decreased cognitive distortions and some improved emotional regulation. The narrative therapy letters definitely reduced her guilt and supported the meeting making as well. Mindfulness tactics, breathing techniques, all really increased her, ability to ground herself and distress tolerance, to handle distress. Behavioral activation. I think the self-care bingo really made behavioral activation easier for her because it became a game. And it also improved her mood and, the daily structure of her life. The changes that I just observed were like her brighter affect and improved emotional control. Every session we had, she would be less tearful. She reported feeling lighter and more at peace, and reported herself to be more capable of self-regulation. She also expressed some increased communication skills and healthier boundaries with her husband, and fewer marital arguments. And her husband even started to become more responsive and, hold the communication instead of her hogging the communication. As well as, I think she had a greater ability to process the grief without dysregulation. As well as when she did get dysregulated, she was able to handle it and re-regulate herself pretty well. Clinical growth and competence I adjusted the pacing based on her readiness. I used quantitative and qualitative data for the decision making, and again, supervision was used all throughout just to verify progress and prevent my own bias. And I think I improved my own confidence in applying CBT, narrative, and systems theory specifically. The agency evaluation processes again included the GAD-7, PHQ-9, and PCL-5 to track improvement as well as areas needing improvement. And I definitely think that those scores helped with that. Her progress was monitored via the session notes that I completed after each session, which those entailed the mental aesthetics exam, the, what did we discuss, the assessment and plan for the future, and instructions given to her for, if I had given her homework. Some possible future additions to, a similar client or all clients at the agency would certainly be client satisfaction surveys. All the clients reported feeling very unhappy with the fact that because they saw interns, they would see a provider for a few months and then have to start the whole process over with someone else. And so I think, a satisfaction survey that allowed them to express all their opinions would be really good and helpful to all the clients' treatment and progress. Overall, I think this case demonstrated meaningful progress across all counts. Using trauma-informed person-environment lens, I think supported a clearer understanding of my client's needs, as well as evidence-based interventions and NASW ethics guided every stage of treatment. CBT, narrative work, mindfulness, all strategies contributed to her improvements in depression, anxiety, and PTSD symptoms. The regular assessments and reflective practices, I think, strengthened clinical decision-making. The client's symptom reduction and increased emotional regulation, I think, highlighted the effectiveness of the treatment plan itself. Now, Section 2 examines the three major areas, like ethical dilemmas, human diversity and social justice issue, and a policy issue. Each subsection expands on previous reflection papers. The ethical issue centered on clients texting outside of scheduling purposes, which challenged professional boundaries and digital communication limits. Now, the client in particular for this dilemma, her messages were positive, but they did risk creating blurred roles to relationships and confidentiality concerns. When she initially reached out outside of scheduling purposes, I did respond initially with a brief supportive redirection, and then withheld further replies in order to maintain the agency's expectations, as well as the NASW standards of dual relationships. This balanced compassion with professionalism while ensuring that boundaries remained intact. Now, my personal values of kindness, empathy, and availability made, I think, the dilemma a little bit more emotionally complex internally. I experienced a lot of internal conflict about responding, not responding. Supervision definitely highlighted how personal and professional values intersected during boundary decisions. I had one supervisor who, encouraged and supported my redirection and then taking away my texting unless it was for scheduling purposes, and then another supervisor was like, oh my gosh, isn't it so sweet and awesome that she's telling you how much she appreciates what you're doing, which was just a lot of conflicting opinions. Now, specifically the NASW Code of Ethics from sections 101, 106, and 107 reinforced the need to avoid dual relationships, protecting confidentiality, and to act in the client's best interest. Recognize my own countertransference, I think, allowed me to maintain professional judgment while preserving the therapeutic alliance. I think the dilemma itself highlighted how different agencies can interpret texting boundaries. Like, a lot of the telehealth platforms use texting very heavily. Like, you can just text your provider whenever you want. So I think it really reinforced the importance of using supervision, self-reflection, and ethical standards to guide the practice. Following confidentiality expectations and structured communication policies also supported the competent and ethical decision making. Like my agency, there's a rule that we don't give out our personal phone numbers for these texts. We use like a Google Voice number that we create that gets sent out to all the clients. The HDSJ issue centered on a values-based conflict that emerged during a discussion about abortion with a different client of mine, which I think revealed deeper differences in belief within the therapeutic relationship. Although the client and I both shared Christian beliefs, Christian foundation, our interpretations of faith and morals and decision-making, I think, diverged in ways that required careful navigation to avoid bias, judgments, or disrupted rapport. During the discussion about abortion, strong differences in interpretation of the same faith tradition surfaced. So my client was very strongly against abortion, and I'm more so aligned with, if you want to choose that, that's okay, but I don't think I would ever. I think the moment highlighted how cultural and spiritual identities can appear similar on the surface, yet differ significantly in lived meaning. I think the situation itself required a lot of cultural humility and self-reflection to prevent bias from influencing engagement. Initially, throughout the conversation, I noticed my own internal reactions influencing the conversation in the way that I was responding to her and questioning her on her beliefs. I think these reactions aligned with countertransference patterns described in clinical literature, where therapists may emotionally react when client beliefs conflict with their own. Social justice perspective and the ADEI framework. I think that this movement emphasized how personal narratives, systemic influences, and cultural identity can intersect in therapy. The ADI model illustrates how social workers must consider how oppression, lived experience, and culture narratives shape client beliefs and emotions. I think by centering her perspective rather than my own framework, I supported autonomy, dignity, and culturally responsive practice. This also strengthened our therapeutic alliance and ensured that differences did not become barriers in her care. Again, I was able to recognize my own internal judgment and immediately guided the conversation away from how I was guiding it initially, which led her to share something personal about how she had an abortion when she was, I think, 15, she said, and how she deeply regretted it, which also went to show, why she believed what she believed. The policy issue was centered on the client's difficulty accessing legal assistance for custody and divorce matters, which reflected systemic gaps in services for low-income and uninsured adults. The client in particular for this case has been separated for 3 years from her husband, but hasn't finalized the divorce, and wants to sort of change the limits of custody between her husband. And because of her low income and being uninsured, those barriers limited her ability to navigate court process, protect her children, and secure her own safety and stability. Her situation demonstrated how socioeconomic status can intersect with family law policy and create unequal access to reputation and advocacy. The lack of legal support increased her emotional distress and delayed decision making for 3 years, illustrating how policy limitations can worsen client vulnerability. Because she could not afford an attorney, the client relied on the free legal services. I even tried to refer her to free legal services, and that's when she told me that she had already used them 2 times prior. She was forced to use fragmented information, peer advice, and overextended public services. Initially, she had a lot of assistance, and then later on, she had, little to no assistance from those services. And I think these circumstances placed her at a significant disadvantage in custody negotiations and divorce proceedings. Her experience, I think, reflects serious concerns about unequal access to justice, which is an issue highlighted in the Legal Services Reauthorization Act of 1992, which emphasizes the need for extended protections for low-income families. And I think her case specifically demonstrated that such protections remain inconsistent in practice and could really use some help. As her clinician, my role initially was to help her with the anxiety, providing referrals, but it later became supporting her documentation needs and helping her understand her rights. Again, I did encourage her to continue seeking out the free and low-cost legal services, but I also helped her prepare emotionally for the court-related stress and, getting her documents and the way that things should be said, which really in turn eased a lot of her anxieties. I think this work aligns with the social work policy expectations that clinicians promote equitable access for services and advocating for the clients facing systemic barriers. I think her case illustrated how clinical practice and policy work intersect, especially for clients navigating poverty, trauma, and legal system complexity. Obviously, there were limits to what I could do because of agency policy and ethics, but I made sure to do what I could, and it certainly helped. This section in all highlights how ethical HDSJ issues and policy issues shaped my own personal development as a clinician. Each challenge I faced, even the ones that I didn't even discuss, required deep self-ethical reflection and consultation, all grounded in NSW Code of Ethics and agency policy. These experiences strengthened my cultural humility, ethical decision-making, and advocacy skills, but also my self-reflection and ability to avoid countertransference. I feel like it deepened my understanding of how client needs intersect with systemic barriers and social justice concerns. Overall, I think the lessons gained reinforced my commitment to competent, ethical, and client-centered practice. And I think they also prepared me to navigate real-world situations with greater confidence and professional integrity. Thank you for listening to my presentation. I will be linking the video because I was not able to narrate it, record and show the presentation at the same time because I just used Google PowerPoint. But again, thank you so much for listening, and all in all, I actually really enjoyed my clinical experience at the agency that I was at. I learned a lot. I also learned a lot from my field supervisor and my field professor. A lot of the self-reflection needed came from them as well. Bye.